Program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson. I'm pleased to have with us tonight Professor Richard Ackermann, who is in charge of geriatrics at Mercer. And welcome, Richard.
Well, thank you for asking me.
Now, that's a rather complicated title or word, geriatrics. What exactly does that mean? Could you discuss that?
Well, geriatrics generally refers to the care of people who are over 65. But most 65, 70-year-old people are pretty healthy. So really we concentrate more on the very old, people over 85 or 90 or so, or people who are frail, cognitively impaired, or starting to get some of the complications of aging that require a lot of help.
Now, Richard, how did you get interested in this? I mean, what direction has your medical career taken to get you to this point? Why don't you talk about that?
Yeah, I went to Duke Medical School, and then I was trained in the Navy.
Really? A Navy guy, is that right?
That's right. So I was sent to a Navy clinic where most of the patients are active duty people who aren't very sick.
Yes.
And so I volunteered to take care of the retirees because I thought that would be more challenging.
Yes.
And I took care of snowbirds in Florida for a couple years and got really interested in better care of older people.
Yes.
And then I sort of concentrated my career on that. But I've been here in Macon now for almost 20 years, taking care of older adults, and I really love it.
Well, that's a special kind of population, isn't it? I mean, we all, if we're lucky, we are going to face old age, and life has been extended. I mean, it's remarkable how long people live these days, isn't that right? I mean, the chances of a 65-year-old female reaching 90, that's a big number, isn't it?
Right, it's almost 50%. The 65-year-old woman can expect to live today about 18, 19, 20 years on average.
Yes.
And many will live a lot longer than that. You know, in 1900, the life expectancy was about 50.
Yes.
And in 2010, it's close to 80 for women, a little less than that for men. So we've gained 30 years of life expectancy in just one century, which has just changed everything about the way we live in medical care.
That's an absolutely extraordinary statistic, and I'm not sure the public understands what's happened. I mean, in a state of nature, no one, the whole population living to this advanced age is just a miracle. I'll make one little comment that the age that of retirement is 65, and this may be an apocryphal story, but allegedly the Otto von Bismarck in Germany picked that age because his actuarialist looked into the life expectancy and discovered that 90% of the population would be dead at 65. I mean, and now that's a very that road mark is not the end of life at all, is it?
Right. Your history is exactly right. 65 was picked out of the air by Germany in the late 1800s, and then it became incorporated into law in our country because Social Security came in 1935 and picked 65 because the Germans had done so, and then in 65 we chose 65 for Medicare. So it's arbitrary. When you turn 65, you don't become old. That's ridiculous.
So if people think that could be a mistake, couldn't it? I
Absolutely.
mean, if you're 65, one reason I know that, Richard, is I'm 65. I still can tap dance, and I mean, there's no reason to, one can expect several vigorous decades.
Yes, I don't expect to retire at 65. I just think that's out of the question.
Well, so what are we doing with this large population? What are some problems they face, and how can we make these years as good as possible? What are some tricks?
Right, it is a large population. In Georgia now, we have just over 1 million Georgians who are over 65. In 20 years, in 2030, we'll have just under 2 million. Now, most of those are healthy people, but a large number of them acquire the frailties of aging. Eventually, we get disabilities, we get diseases, we need surgeons like you. We need medical subspecialists, we need hospitals, even things like nursing homes, home care, hospice. And the older we are, the more likely we are to utilize these. So at age 85, for example, about 40% of people have some degree of dementia. That's very sad. That means 60% don't.
Yes.
But that's a large number of people that are frail and need pretty much around-the-clock nursing attention with periodic medical attention, special needs, high healthcare costs for those folks.
And so one of the things you do as you minister to this population is it's a family unit issue, is it not? So
Yes.
you have the children of the elderly parent. What does one do? What's the appropriate residence for an elderly
Right.
relative? And that's a complicated story, isn't it?
Yes, I have a 102-year-old who comes with his 79-year-old daughter.
Yes.
So that's not so unusual these days. He still lives at home. He still walks to the mailbox and back. He goes to the health center, the health club, twice a week. He gets in his wheelchair up to the door, and then he walks in and walks around the track once. So he has his routine to maintain his vigor. So we like to keep people independent, functional, delay institutionalization, try to keep people out of the hospital, organize their medical care so they can remain as functional and independent as possible.
And as one sort of, if we're lucky, we're all going to face old age. Is there a way to minimize the ravages of old age in early youth? Should we say we may have some young 40-year-olds out there? I mean, is exercise a good thing? I mean, any
Right.
comments about
Right.
what's a good thing to be ready for old age? What
We
are some
mentioned
tricks?
there are no gimmicks, so there's no intervention that stops aging, delays it, or reverses it, despite all the billions that are spent on tonics. But what you mentioned is probably the single most important thing, physical exercise. Physical exercise delays the disabilities, both cognitive, or mental disabilities,
yes.
as well as the physical disabilities of aging. The most important thing you can do to stave off dementia is physical exercise. The second most important is brain exercise.
Yes.
Thinking, writing, doing crossword puzzles, playing board games with people, playing a musical instrument, joining a club, things like that. Those two things are really important. Probably the third one is a moderate, effective diet.
Yes.
That's maybe not a southern diet,
Really?
but a
Not
diet
much
that's
fried chicken?
not a lot of fried chicken, like a Mediterranean
Yes,
diet has been
yes.
shown to improve cardiovascular as well as mental health in older people.
Well, how about a little red wine? Is that a good idea, Richard? Would you suggest that on television?
I don't recommend people who don't drink start drinking.
Yes.
But people who opt to drink, about 40% of older people are teetotalers.
Yes.
And I don't encourage them to start drinking when they're 70 or 80.
Yes.
But for the majority of patients who are, I do recommend that drinking in moderation, particularly red wine, as you mentioned, keeping the down to 4 to 6 ounces per day really is.
That's not too much, I don't think.
For most patients, not all, you should talk to your
Yes,
doctor.
yes.
For most patients, is really a boon to your health. I've even prescribed wine in the nursing home on the medicine cart,
Yes.
poured for the patient as a routine part of their
In other
health.
cultures, there's nothing shocking about that. Is that right? In a European venue, I mean, that'd be very, very
Oh,
common.
right. The
Yes.
Europeans eat that Mediterranean diet. They drink red wine. They live longer than we do, but not
Yes.
just longer. They live better.
Yes.
They have less disability, less institutionalization. They live more vigorously on average than we do.
Now, Richard, it's been said that a very aged population exists, or people that are very long-lived, or in the Caucasus. There's another Georgia out there.
Yes.
I mean, I think many people may not know that, or maybe they do. But in the Caucasus Mountains, there's a country called Georgia, and they have a very long-lived population. Is that true? And
Well, people have looked at these very carefully. There's Georgia. There's a group in Okinawa. There are several places, and when they've looked at them carefully, most of that falls away when people look very carefully. Birth certificates and records are not very accurate. Fathers and sons, mothers and daughters have the same names, so people get confused. There's not, even in our country, I have patients who are 90 and 100 years old that have no birth certificate.
Yes.
They really don't have one. They weren't kept in Georgia
Yes.
in 1910. And so those are mainly, there are no Methuselahs or
Yes.
places where there's an elixir or a fountain of youth where everybody lives to be 110 or 140. But more of us are reaching that 80, and we can expect that to happen. That rate of increase is starting to slow. The easy stuff has been done.
Well, what is the easy stuff?
Well, the easy stuff was things like safe water, the interstate highway system, telephones, ambulances, the institution of hospitals, where you could get trauma care,
Yes.
things like that. Now, the tinkering we're doing with new medications and things help, but the big stuff, the public health things
Yes, yes.
that changed health so dramatically, like immunizations, making
Yes,
childbirth
yes.
safe, That's been done. So now we're working on, you know, fine-tuning the treatment of heart failure and making surgery safer and anesthesia safer. And those are all wonderful things, but they don't have the dramatic effects that things did in the, say, 30s and 40s.
I guess one thing is to, and this is a statistic that's often quoted, different countries have higher life expectancies, and I think particularly the Japanese, they're way up there. But is that a genetic issue? I mean, is there, or do you think it is a dietary event or exercise?
I don't think it's genetic. The Japanese, 22% of their population is over 65, and we're 13. So they have a very old population, but when Japanese move to this country, within 2 generations, they acquire the American lifestyle and the American longevity. So that's not their genes.
Yes.
It has to do with their diet and their culture and their way of life. I don't know exactly which part of it is, but it's not. I think genetics are a minor part. Of course, we don't deny genetics. You know, some people have early heart disease and early cancers, but I don't think the Japanese or certain populations like that have a genetic advantage. I think it's probably more their culture, their diet, their exercise, and also in that society, older people are venerated. They're a very distinguished part of the population, and our society is much more youth-oriented.
So isn't that when, in some cultures, the idea is that you'd expand your age. You try and pretend you're older than you were, and others, it's sort of a youth-oriented arrangement here. People often try and knock a year or 2 off of their age. Is that,
right.
And maybe that has
we spend a lot of money on plastic surgery and nostrums to keep us, you know, looking young.
Yes. Well, now, in an older patient, they're often confronted with enormous medications, different kinds of medications. What are some of the problems that your patients face? I mean, just compliance with medications, is that a big deal? And
right, so compliance means is the patient actually taking the medicine. Older people, surprisingly, are actually more compliant, sometimes to their detriment.
Yes.
Because one of the biggest problems I see in geriatrics is people taking too many medications. Sometimes people taking 10, 12, 15. I've had people taking over 40 prescribed medications.
Yes.
Now that can't possibly be optimal.
Yes.
And so lots of physicians are involved. Sometimes the patients don't tell each doctor what the other doctor is prescribing.
Yes.
Some of the patients maybe have some memory problems and might not always know what they're taking. They're taking 2 drugs that are the same thing. They have different names.
Yes.
So one of our big tasks is to take it head on. Do the paper bag trick where they bring in their medicines. I line them all up. It's a little scary.
Yes, yes.
You go through every single medicine and say, what is the reason for that medicine? Is that a 2011 reason to have this medicine?
Yes, yes.
And go through each one. Is it the right dose?
Yes.
And we often can find ways to dose reduce, get rid of certain medications. And this has been very successful. We've had patients that came to the nursing home essentially for their terminal care who were able to graduate from the nursing home and go back home or go back living with a family member when we finally stripped them of drugs that really weren't helping them anymore.
Now, one of the things that I guess it's in our popular, well, I guess our political debate over healthcare issues, and the words death panels have been tossed out there, so that's a rather inflammatory turn of phrase. But one of the things that happens is what's the appropriate amount of health care for an elderly person? What should that patient get in the way of high-tech treatment, intervention, and often very expensive, and is it in the patient's best interest to have that? That's a rather complicated ethical questions here. And so maybe I can toss you a pitch and see what you can do with that.
That's really complex. Let me start. Just so that everybody understands, there really is no such thing as a death panel. There never has been. There never was. A death panel was the idea that somehow we were going to deny health care and not treat grandma's pneumonia.
Yes.
What the health care bill that was passed had in it originally was a provision to allow physicians to talk to their patients about making plans for advance directives. This was not required. It was optional on the part of the doctor as well as the patient. There was no requirement about what conclusions you came to, just that you should talk.
Now that sounds pretty reasonable to me.
Yes.
I mean, you're a reasonable. Doesn't that sound nothing wrong with that?
Right. So now, for example, I can't bill Medicare just to talk about advance directives. I have to tie it to a disease.
Yes.
And that's okay. I usually have a disease I can talk to.
Sure.
But what they want to do is allow you to speak, say, every year, if you wanted to, and have this conversation, say 15, 20 minutes, where your patient could tell you, this is what I really value. I want to be on a breathing machine. I don't. I value quantity or quality or whatever their choices are, and you could document that for them. But your question is much broader than that. The older people do require a lot of health care. They consume, although they're only 12 or 13% of the population, they're 40% of prescriptions. In our hospital at the medical center, there are almost 50% of our patients now are insured through Medicare. That's because that's who's sick.
Yes.
You know, when you're 80, you're more likely to be sick when you're 40.
Yes.
Most of the excessive costs, though, in older patients is not real high tech. It's not 6 weeks of ICU. It's just the medications for heart failure and hospitalization for pneumonia. So I think the best way to handle that is to talk to people and connect with them and find out what their goal of care is. I'll give you a short example. Your goal of care could be cure. You do this a lot in neurosurgery. You take out a brain tumor, you clip an aneurysm, and you hopefully cure it, and the person is whole again. Sometimes we can contain a problem. Say they have diabetes or a disease like that. We don't cure that disease, but we can put some boundaries around it. We can reduce its ravages. We can lower the risk of stroke. But for many patients, for most of my patients, as they get closer to the end, we can't cure and we can't contain, but we can always comfort.
Yes.
And so our goal will change towards, let's relieve your shortness of breath. Let's be aggressive at managing your pain. Let's make sure you're nausea. Let's keep you mobile.
Yes.
Let's try to keep you out of the nursing home. That's a different goal than doing a procedure or curing something. It's just as valuable.
Yes.
It's a different slant. And it's not all of the other. You don't go from cure and say, okay, we can't cure anymore, we just go to care. We can do it all together. So for example, when I go in the hospital for surgery, I expect to have expert anesthesia, expert surgery, low complications, but I also want some pain medicine.
Yes.
I want all of it.
Yes.
And I want a doctor who will talk to me. So I think that's what we try to do is organize. I think it's a combination of high tech and high touch. And you want both of those. You want somebody who can look at the whole picture and say, you know what, this complicated person in front of me, how can I really help them? Is it surgery? Is it taking them off of medicine? Is it adding a medicine?
Yes.
What is the single thing or 2 or 3 things I can really do to make their life better? And be open to a wide range of options.
Yes. Well, maybe you can list some of the infirmities of old age. I mean, so what have you, I mean, for instance, osteoporosis in females. I mean, what are some things that people might do trying to get ready for what's coming their way? There are different issues that are that appear. I mean, controlling their diabetes at an early age, hypertension. I mean, isn't that a big problem about people that come to you with, I guess, having neglected different kinds of organ systems that?
Oh, sure. And so if you haven't taken care of your blood pressure and your diabetes for 10, 15 years, then you essentially age a lot faster. You get the stroke and the heart attack and the disabilities 10, 15 years earlier than would be under optimal circumstances. And so chronic diseases, you mentioned many of them, osteoporosis, high blood pressure, diabetes, congestive heart failure, things like that are very common. What you want to do is have a primary care doctor and when necessary subspecialists that will identify them and empower you to manage these problems. Take assertive control of your medical problems. If a person's diabetic, they have to manage it. The doctor's the advisor. And what we can do is try to put together a plan that works. Now, some of the things we see in geriatrics, we see a lot of cognitive impairment. That's very sad, and we have to deal with that forthrightly. Dementia, confusion. We see a lot of falls, and that can be the beginning of the end.
So, is it an advantage to live in the sunny South where people don't slip on the ice and break their hip? I've heard people say that.
Yes, I think that's true. Yes. We don't have as much of that. Although we have a lot of osteoporosis, we have a lot of hip fractures, and that can just be the start of a spiral downward. A person can be doing fine, maybe not great, but they're living by themselves at home, tenuous environment. The kids aren't perhaps exactly thrilled with mom, but it's okay. And then something happens.
Yes.
She gets pneumonia, she has a minor surgical procedure, and just never can snap back.
Yes.
And you send her to rehab, and then she ends up in a long-term nursing home, and it just spirals down. And our goal is to try to arrest that, is to try to deal with that and try to prevent that premature slide towards institutionalization.
So falls, it really, that's a rather, I'm not sure I've heard that stated so articulately, but that's a big deal, isn't it? If you're an older person, being really aware of
falls.
And very careful
and another thing is what we call fear of falling. I've seen several patients in the last couple of weeks that have restricted their lives because they're afraid they'll fall. So now they don't walk anymore, and they want me to prescribe them a scooter. And I said, well,
are these the scooters that are advertised?
Oh, yes.
Now, are those free, Richard? Or?
They're not free. Well,
somebody must pay for them.
Well, right. Medicare and insurance will pay for them if you meet criteria. The woman I saw this week, She saw it on television. She wanted one.
Yes.
And so I told her, well, do you walk? Well, yes, she walks. Her problem was she has to walk a long ways in her assisted living, and she gets tired. And I told
Yes.
her, you don't need a scooter.
Yes.
And so what we worked with her, I got a physical therapist to see her. I got her what's called a rollator, which is a kind of walker where she can, when she gets tired, she puts the seat down and sits.
Yes.
Now that's keeping her mobile.
Yes.
It's keeping her reflexes strong. It's keeping her
Yes.
muscles strong. She does not need to sit in a scooter and push a button and condemn herself to never walking again. So it was a hard sell for me.
Yes,
She
yes,
really wanted the scooter.
Yes, yes, yes.
And I
Well,
felt like I was being a little mean to say,
they look like fun. I mean,
you know, I want to keep you mobile. I don't want you
Yes.
to break your hip. I want you to stay out of the nursing home. Let's
Yes,
do
yes.
this first, and I'll reevaluate you and try to keep you out of the scooter.
what is the, I guess the direction that old age takes in regards to residents? So initially, people would be in their home. How does that proceed? Maybe they.
Right. So most of us haven't picked out our nursing home. You know,
Yes.
you've picked out Shady Dale, and you're going to live your last 6 years there or something. We hope to live in our home, I
Yes.
think,
Everyone wants to live in their home.
independently and just die in our sleep. That would be
Yes,
lovely
yes,
after a
yes.
long and productive life,
Yes.
contributing to our jobs and our families and
Right,
community
yes,
and church.
yes.
Well, unfortunately, some of us are going to acquire frailty and are going to have to live with our children or
Yes.
other family members. It may not be our first choice. It may not be their first choice.
Yes.
So you have that option. We also have in-home care. And so there are caregivers, home health aides.
Now that's a pretty good idea, isn't it? I mean, is that easily obtainable? I mean, can people?
I wouldn't say it's easily. If you have resources, it's easy. But even the state of Georgia has some really good programs for people on Medicaid or near Medicaid. And the idea is if we provide some services like that, we don't end up paying through our taxes for them to be in the nursing home.
Yes.
The state has these waiver programs where if a doctor certifies they have certain needs, we can send people to the home to help them bathe, perhaps do a
Yes.
little light housework, make sure they're eating, make sure their medications are laid out.
Yes.
And then maybe we can delay their nursing home placement by 6 months or 18 months. I've seen patients that came to me with the family requesting a nursing home placement.
Yes.
I said, of course I can do that. I know how to do that. But if I could come up with another option,
Right. Yes.
would that be helpful? And they're just thrilled.
Yes,
They had no
yes.
idea that this was possible. So if we can come to that, or say moving to a place like what's called an assisted living,
Yes.
where it's
Now,
not
what
really
exactly is assisted living?
Assisted living is where you live in perhaps a safer environment, but there really isn't the 24/7 nursing
Yes,
care.
right, yes.
Some of these places do have an LPN from, say, 8 in the morning till 4 at
Right,
night, or
yes.
somebody who acts like a nurse, somebody who can lay out their medicines, but they don't give you your medicines.
Yes.
They can't give injections. They can't do
Right,
treatments
right,
like
yes,
nurses can.
yes.
But this can be very useful. I've had patients who have spent 5-6 years, and this becomes their home. They love these places,
Yes.
and it becomes an environment where they can stay.
So there are environments that people can adjust to that are pleasant for them.
Right, and then if on the other end, you've got some very nice places. We have continuing care retirement communities where you age in place is the term, where you go to an independent home, then as you become frailer, you move to their assisted living, you move to their nursing home, to their dementia unit if necessary, utilize hospice, all on the same campus. That's only available to the wealthiest, say 5 or 10%, but when
Yes.
it's available, it's a very nice option for people.
Yes. Now, one of the things that often happens in old age is there are impairments of vision and hearing, and how important is to keep that maintained? Is that a
Yeah, so that can be crucial. That sensory input, you know, a lot of pleasure comes from communication with people, perhaps watching television, reading books, and so getting cataracts taken care of, getting glaucoma treated, just convincing an older person that their hearing really is failing.
Yes.
For example, Medicare will pay for the initial workup, the
Yes.
evaluation of hearing impairment. They will not pay for the hearing aids.
Yes.
So I say at least go and get the audiogram. Let this expert in hearing assess you,
Yes.
and then you can decide whether you want to take the next step and get a hearing aid or whatever's decided. But doing the assessment and convincing the person that it would benefit their life is important.
It turns out to be a big thing. Another thing that's rarely commented on, I think, in debate on healthcare is dental care. I haven't heard anyone really discuss that too much, but many people have had real problems with that. That by the time they're elderly, it's really a very difficult issue.
That's right, and the majority of older people now who are over, say, 70 or 80 actually are edentulous, which means they don't have teeth. But people
Really?
coming up my age
Yes.
are not that way.
Yes.
And we've had better dental care. You know, we didn't grow up through the Depression where there were no
Yes.
means. And so that is not a routine part. Many people don't have adequate dental insurance, that's true. And I'm not a dentist, so I have
Yes.
to tell people, you can ask me the question, but I have to
Yes,
send you to
yes,
somebody.
yes.
And it's hard sometimes to find a dentists who will take people who are 70 and 80 years old. It's a special population to manage.
Yes. Now, this must be a conversation you often have, Richard, is an end-of-life scenario with a family as you're discussing how aggressive to be and what should you do? What are the parameters that how do you get into that discussion? What would you talk to a family there
right.
about that?
Sometimes there's a crisis that forces you into this conversation. And so a person ends up on the ventilator. They've had a terrible hemorrhage into their brain. They have bad pneumonia and we can't get them off the breathing machine, things like that. That's pretty obvious that we must speak. But I think even that's a little late. That we haven't had the person, for example, if the person had this terrible brain hemorrhage, I can't talk to them now.
Yes.
It's much better if their primary care doctor a year, 5, 10 years before had a preliminary conversation
Yes.
and say, you know, here you are, you're 76 years old, you're reasonably healthy, you've got high blood pressure and diabetes. Yes. One of the things I'd like to do for you is talk about some of the wishes that you have about directions of your
Yes.
care should you get really sick. And I have these conversations with people and I get some firm directions sometimes.
Yes.
I don't ever know what's going to come out of their mouth. And it's good for me to know that. We document it.
Yes.
We put it into a written form so the person can take it with them. Unfortunately, most of the time that doesn't happen. And so we have to react to the crisis. But that's okay. We can still talk to people or their caregivers.
Yes.
I think be excruciatingly honest with people. If we don't know what the future is, we say it.
Yes.
I say sometimes this is nebulous. It's unclear to me what
Yes.
your recovery is. I have to be honest. Sometimes I have to say the doctors, the different experts, they don't agree.
Yes.
That's human. And I just reveal that to the family that your doctors aren't 100% sure what the outlook is. Some of them think we should do this, some think we should do that. And then what we do is really empower people to give us overall directions. It's not like a Burger King where you have it your way, where they tell you everything to
Yes,
do. It's
yes.
just overall guidance. Tell me what your mother in
Yes,
general would tell
yes,
us.
yes.
Oh, she would kick me around the room
Right,
for
yes,
letting it get
yes,
this
yes,
far. Or
yes.
she valued every second of life. She would regard every day of life as a precious gift from
Yes,
God.
yes.
Those are two examples,
Yes.
and that helps to inform me what
Yes.
options we should offer for people. I do find, though, when you give people the full range of options, a large number of people choose some restrictions.
Yes.
Not all.
Yes.
But a large number will say, I don't want that feeding tube, I don't want that tube down my throat permanently, I don't want to go on, experimental cancer therapy, I don't want a transplant. So I think we should give those options to people and support them whatever they do. They don't have to make the decision that I want them to make.
Well, Richard, I think we're all going, if we're lucky, we're going to face these older years, and I'll give you 20 seconds to make a concluding comment. So anything you want to make a comment about? We've talked about a lot, but
I think aging is a success story in American life and medicine. I think we need to face aging with a very positive attitude, stay healthy, get a good relationship with a primary care doctor, and exercise your brain, your body, and eat right.
well, thank you. That's great advice, and I'll write that down and personally remember it. So we're delighted to have you here, Richard, and we hope to have you back again. And so thank you so much for being with us. Thank you.
I'm delighted.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.